Well, hello everybody. How are you? Nice to have you here with me. We're just going to give a minute or so, let people come in. Hi, friends. Oh, some familiar names on here. Hi. Hi. So, welcome to the webinar tonight. So I wanted to put something together that sort of addresses some of the updates in treatment of Lyme disease and give you some information on that. This is a two-part series. And so I will make sure that you have the link for the second part, and I will talk about that in just a minute, what we're going to cover tonight and what we're going to cover in the second part of the webinar. So I will say this, if you have questions, I'm just going to go through the material, the information. If you have questions, please pop them in the chat or the Q&A. I will come back to them at the end. So I won't be taking questions throughout. I will be taking questions at the end. So yeah, just go ahead and pop them in the chat. That would be great. So before we get started, just a brief introduction. My name is Dr. Nicola Ducharme, and I'm the owner and founder of Restore Medicine. We are an integrative medical practice based in San Diego in California. And I've been working with Lyme disease since about 2004, 2005, aging myself here. I first started practice as a naturopathic doctor in 2003 in San Diego, worked with autism for the first couple of years, and that was awesome. But then Lyme kind of found its way to me, and I started working with more Lyme patients, and then it's just really, it's gone from there. And that's pretty much what I do. The last few years, I've also been working a lot more with mycotoxin illness and with mast cell activation syndrome. So all of these things go together. We know this. And so that's our wheelhouse. So I'm going to share my screen with you. Share this. All right, hopefully you see that. I do have Carla with me, just kind of monitoring. So Carla, if you can just let me know, thank you, that you can see the screen. That's perfect. All right, so new frontiers in Lyme treatments, updates on emerging and adjunctive medications. Giving you a little bit of introduction there. Just also wanted to let you know I'm also now licensed in the state of Arizona. So I'm very much based in California, live in San Diego, but I do work with patients all over the country. It's just the limitation is my license allows me to prescribe pharmaceuticals for people who are within the states of California and Arizona. But I do work with people nationwide and even abroad in more of a sort of consulting role. But it's exciting to be licensed now in Arizona too, since I do have a bunch of patients there. Just a little disclaimer before we jump in. This presentation is for informational and educational purposes only and does not constitute medical advice. The content presented is not intended to diagnose, treat, cure, or prevent any disease. And always consult with your qualified healthcare provider before making any changes to your medical care or treatment plan. So why are we having this conversation? Why do new and novel medications matter? Well, they matter because people are still sick. People are still really sick, and many people are still really sick. And although I am typically not highly political, and I'm certainly not going to go down the politics of Lyme, there is some slight improvement, as I can perceive, in terms of acceptance of chronic Lyme, but there's still a long, long way to go. So there's still a lot of people that are out there struggling, suffering, not getting accurately diagnosed, not being, getting the attention, the medical attention that they need. And so we have some great doctors, great pioneers in the field who are out there, like looking at different medications, looking at different protocols, piecing it together, sharing information. I'm part of the ILADS organization, which is the International Lyme and Associated Disease Society. I've been a member of ILADS for a couple of decades now, and that's where the doctors hang, the practitioners, not just doctors, other practitioners too, that are really trying to make a difference and that are kind of looking into some of these things. So I'm just sharing some of the newer information tonight, certainly not a complete set of information, but I tried to put in as much as I could on these particular topics. So we have persistent symptoms despite standard protocols. Every ILADS conference, all my patients are like, what's new, what's new, what's new? And for quite a few years, I was like, not that much. But now it's kind of cool. It's like, oh, there's some new things. This is exciting. So we need to always be looking to broaden our protocols. We have these complicating factors, biofilm, persister cells, co-infections, that just make the chronic infection piece more complex. And then we have other things like the autoimmune element, mold, mycotoxins is a huge, huge piece, mast cell activation syndrome, which, Lyme and mold, in my view, are the two biggest triggers of mast cell activation syndrome. So I'm seeing more and more of that. Chronic immune dysregulation. It's just these situations are getting more and more complex. So we need advanced, integrative, and personalized strategies, right? There's never a cookie cutter approach. There's never one protocol that works for everybody. One person may thrive on a medication and another person may feel horrible on that medication. So it has to be very individualized and personalized. But I really love the integrative approach, and that's how I practice is, the best of both worlds, using medications when we need them and using, herbs, supplements, nutrients, naturopathic support. And just putting those two things together has been what's given me the best results over the years. All right, so part one, which is now, we are looking at an overview of emerging antibiotics/medications. I use that antibiotic term fairly loosely. Ivermectin, which on label is an antiparasitic, seems to have anti-inflammatory effects as well. Piperacillin, which is more future applications, but I had a lot of people asking me about it, so I thought I'd kind of give the facts here of where we're at with that currently, and where we're hoping it might head, or some possible future applications for that. Tafenoquine is not a newer Babesia agent. It's been used for other things, but we're seeing it now used more for Babesia, and that has some good promise too. Methylene blue has proven to be amazing in a lot of my patients. Has antimicrobial effects, neuroprotective, antioxidant, effective against persisters. So we're going to talk about that. And then Dapsone, which is an antibiotic that Dr. Horowitz has really pioneered in the application for Lyme. And so that addresses persister cells and disrupts some of the biofilms. So that's kind of our lineup for today. And then on November 20th, we're going to do part two. It was too much information to just put all in one hit. So part two is other notable treatments, not so much the antimicrobials, if you will. So I'll be talking about low-dose naltrexone, or LDN, for immune modulation. GLP-1 agonists like semaglutide, tirzepatide. This is a really exciting area to me. Like, I have seen a lot of benefits to my patients. They are thought about, out in the general population as weight loss for diabetes, etc. They certainly do offer metabolic support, but I'm also using them in my patients who aren't looking to lose weight, just at low doses. We don't build up. So the word microdosing, I think, is a little bit overused, but just low dose use for neuroinflammation modulation. And I have seen tremendous things. I'm also seeing some benefit in mast cell activation syndrome. So the GLP-1 agonists are to me, a very exciting area. And then SOT therapy, which has been renamed Q-Restrain. So I want to put them both there, is more of a gene silencing therapy. So that's more targeted pathogens designed to inhibit pathogen replication. And I'm using that a lot in my practice and seeing good things with that also. So that'll be part two. Carla, I'm going to ask you to pop in the chat the link to register for that. You do need to register separately. So we'll pop the link in there, and then I'll pop it in the chat at the end as well, if you still need to register for that one. So kind of how am I thinking about this? We want to look at, starting with Borrelia, like what have we got? Talking about ivermectin, piperacillin, like I said, more future plans for that, Dapsone, methylene blue. We need to target co-infections. So we're talking about tafenoquine, methylene blue again, supporting mitochondrial and neurofunction, methylene blue. Are you seeing a trend here? Addressing persisters and biofilms, so Dapsone, methylene blue, modulating immune response, that's where the LDN comes in, supporting metabolic and neuroinflammatory pathways with the GLP-1s, and then snuffing out these pathogens with the SOT and the gene silencing strategies. So again, we're kind of putting this together in like an integrative kind of approach, but that's kind of the logical flow of talking about some of these newer therapies. that are getting more popular. So let's start with ivermectin. And in some ways, ivermectin is kind of the least clear cut. So ivermectin is an antiparasitic medication. Like on label, it's approved for strongyloidiasis and onchocerciasis, which is also called river blindness. It's got a fairly narrow application, like on-label FDA use. So they're both parasitic worms, and typically it's being used for parasites, more so worms or helminths than the little microscopic parasites. So it does raise a question about effect on babesiosis. Babesia is a parasite. It's not an intestinal parasite. It lives in the red blood cells. So it can cause hemolysis and destruction of red blood cells. But it still is in the parasite family. Ivermectin seems to have some antiviral properties. It became very popular in COVID times. I have a horse, and I can tell you that I could not worm my horse during COVID because the tack store had no horse wormer on the shelf because people were buying it up and taking it for COVID. You can also, and would be my suggestion, get ivermectin compounded. It is a human medication. It's not just an animal medication that humans were taking. It is a human medication, but I don't advise getting it off the shelf from the horse tack store because you don't know what else is in there. But it does seem to have some antiviral properties. And if I have a patient that comes to me and says, I have COVID, what should I do? It's first thing is a 7-day course of ivermectin. And it seems to help people through. We were also using it as a bit of a prophylactic. So it seemed to have a lot of benefit there, even though it wasn't widely accepted in the medical community. Does it have antibacterial properties? So is it actually effective against Lyme, or is it that it's working in more of an anti-inflammatory sense? We don't really have clear-cut answers on that. That's why I said ivermectin is, in some ways, the more foggy and the more vague of these medications, because I'm not crystal clear on which mechanism is helping, but it seems to help. And so we'll take that, right? We'll take that for the win. It's a very safe medication. So back to the antiparasitic on label, and I know this got worse during COVID and quarantine, like pharmacies were instructed not to dispense ivermectin. And so it got harder to access through regular pharmacies and regular prescriptions. It's quite widely available through compounding pharmacies. But depending on dosing, which we'll talk about in a minute, I typically don't try and push it through regular pharmacies. They have called my office many a time and said, what's the diagnosis code? And looking for some evidence. So intestinal parasites will generally work, but I have been challenged on that quite a bit. So depending on how we're trying to dose, if we're outside of standard dosing, then compounding is for sure the way to go. I put anti-tumor here. I have not delved into any of this research. Like cancer is just not my wheelhouse. So I haven't even looked at this, but I know there are doctors out there using ivermectin in cancer treatment protocols. So I popped it on the list with a question mark. All very much off-label, I will have to say. So when and why to consider ivermectin in Lyme? So if there is suspicion of intestinal parasites, sure, it can help there as well. Symptoms suggestive of babesia, but not responding fully. So again, how much is ivermectin actually getting into the cells and being able to target babesia? I would never use it as like a first-line babesia treatment, but I have seen some of my babesia patients respond well to it. Like I said, that also could be an anti-inflammatory. There's a number of different mechanisms there. But, that is one indication. And I've also found that ivermectin's good to consider, like patients who've been through all the standard antibiotic protocols, people who've tried this, tried that, aren't getting better, kind of don't know where to turn. Sometimes ivermectin is a good thing to do a trial of because it is safe and it's just a slightly different approach. And it's, it doesn't have the same impact on the microbiome as traditional antibiotics. MCAS type reactivity with no clear triggers. I've seen it be helpful for that, probably through the anti-inflammatory application. I think with MCAS or mast cell activation syndrome, we think about histamine and antihistamines and H1 blockers and H2 blockers. And what we forget is that a lot of the chemicals that are, triggered in the mast cells or from the mast cells are pro-inflammatory cytokines. And so we have this huge inflammatory response with mast cell type reactions. It's so much broader than just histamine responses. It's like full on inflammatory responses. And therefore anything that can act as an anti-inflammatory can be really helpful. Plateaued or relapsing progress. So that's what I was saying. If we just need a different approach, we need to try something new. Standard antibiotic protocols aren't working. Standard herbal protocols aren't working. Like whatever the approach is that one is taking, if it's just not quite going the way we want, or it's not going as quickly as we want, then sometimes ivermectin may be a consideration there. Neuroinflammation or migratory pain are just a couple of things I've seen kind of respond well to ivermectin just from a clinical standpoint. And poor tolerance to other treatments. If somebody has a lot of like antibiotic reactivity or med allergies, sometimes ivermectin is a nice workaround that can be tolerated better. So screening considerations. Now this is not, and some of the screening considerations I'll give you today, like deal breakers, right? Like when we're talking about methylene blue or tafenoquine or looking at G6PD, we'll get to that. These aren't like deal breaker things. They're just things to consider other than maybe the contraindications, of course. So one is stool testing for parasites. Now, stool testing is notoriously hard to find parasites on stool testing. It's not to say it doesn't happen. The GI map and doctor's data, the mosaic comp stool analysis are probably the two I use the most for kind of general assessment of the microbiome and gut function. Para-wellness is emerging on my list as more sensitive for the parasites themselves. And that's a lab, I want to say they're out of Texas. But if I really want to hone in on parasites, will use para-wellness. If I want kind of an overview of gut function as a whole, then I'll do a GI map or a comprehensive stool analysis. Assessing Babesia symptoms, of course, like night sweats, air hunger, anxiety, heart palpitations, shortness of breath, dizziness, like all the classic Babesia stuff. It's good to have a good read on that before starting ivermectin so that we can kind of get a baseline and then a before and after. Contraindications, liver disease, pregnancy. There's not a ton of contraindications with ivermectin, which is kind of part of what I like about it. So it's kind of it's an interesting medication in this space. So dosing protocol. Now, again, there's so much range here. There's nothing standard. Some medications were like, okay, this is the dose. I've seen ivermectin done a number of different ways. So, standard treatment on label, pinworms, things like that. 3 milligram tablets is the commercial ivermectin. Adult dose would be 12 milligrams once only. So one single dose, in my view, in the Lyme context is not going to do enough. But that's kind of what you'll get through the pharmacy. So if you're trying to get ivermectin through a regular pharmacy, typically 12 milligrams is going to be the cap, which is why I say go to compounding. So Lyme treatment options: 1 dose daily for 2 to 3 days, then twice weekly, 1 dose every 3 days, daily dosing for 30 to 60 days. I've seen this less frequently, but I have seen it and I have done it in some cases. Gets expensive though, I will say. The dose is based on body weight. So I'd say the range is sort of 12 to 20 milligrams with 15 or 16 being typical. I've heard of some doctors using up to 35 milligrams daily. So I would say my more typical dosing would be like twice a week, 3 times a week, something like that. Spread it out. Not that it gets sort of really toxic to do it more often, but it does get kind of expensive. And I'm not sure that I've seen the efficacy in high dose daily dosing be that much better. Okay, so let's talk about piperacillin. Now, the reason that I included this, like I said, is that I think there was a journal article that came out or something came out about it and hit the press. And so everyone was like, oh, piperacillin for Lyme, what's going on with that? So let me just kind of get you up to speed on that. So piperacillin is a broad spectrum anti-pseudomonal penicillin. So it's in the penicillin family. In clinical use, the brand name is Zosyn, and it's usually combined with tazobactam, which is a beta-lactamase inhibitor. Don't worry about that. So it does exist. Piperacillin does exist currently. Its current use is intra-abdominal infections like appendicitis, peritonitis, like really, really nasty abdominal infections, some skin and soft tissue infections, pneumonia, hospital-acquired and ventilator-associated included, urinary tract infections, gynecological infections, septicemia. It's used for the really big bad infections. It's typically in a hospital setting or an ICU setting or home infusion nursing care for serious or polymicrobial infections. Polymicrobial meaning like multiple pathogens, multiple bacteria. It's currently only in IV use. And so it's not something that we see people getting, prescribed at home. So in the Lyme world, there were some researchers at Northwestern that screened nearly 500 FDA-approved compounds and discovered that piperacillin effectively treated acute Lyme infection in mice at doses 100 times lower than doxycycline. So it works by binding to Borrelia's peptidoglycan cell wall, effectively killing the bacterium without requiring the co-administration of the beta-lactamase inhibitors. So that was that sort of second part of the medication. Like I said, in the Zosyn, it's the two parts combined. In the piperacillin in Lyme did not require that second part. And, at those low concentrations, piperacillin spared the gut microbiome, so could be easier on the gut than doxycycline. So, this could be a game changer if proven safe and effective in humans. It could offer a powerful alternative to doxy, especially for children who can't necessarily take doxy because of the teeth staining, people who don't tolerate doxy, those at risk of chronic symptoms. So it could in the future prove to be a great medication. We're just not quite there yet. So then a second study by the same team also discovered that the Borrelia peptidoglycan, which is the bacterial fragments, persist in animal tissues like the liver and joints long after treatment, potentially contributing to chronic symptoms, and that piperacillin's targeted mechanisms may help address this. So what this is saying is even if the bacteria are dead, some of their shrapnel that might stay in the body and cause problems could be helped or prevented by piperacillin's mechanism. So that sounds very cool too. So things to keep in mind though, it's only been tested in mice in the Lyme context, so we don't know if it works the same way in humans. We'd certainly need a lot of clinical trials. It's far down the road before it would become a standard treatment for Lyme. Right now, it's only available as an IV medication, so it's not something you can go to CVS and get a bottle of pills and take it at home. And right now, it would require hospital treatment or at-home IV therapy with a nurse or infusion center. So it's kind of a big deal. So the research also focused on early infection and just sort of dare I say, simple acute infection, if that actually exists in the Lyme world. But Lyme disease is much more complex, right? With chronic symptoms, co-infections, immune system involvement, none of that factored into the mouse studies. They were just looking at acute Borrelia infection, what was working. Also not yet approved for Lyme. So of course, there's lots of medications where we have off-label use. We just talked about Ivermectin. It's very much off-label use. So it's only FDA approved for other serious infections, not Lyme disease. However, it's just the limitations in my view of being acute Borrelia only, no account for other forms of Borrelia, no account for co-infections, no account for immune system dysregulation, all the things that go with more chronic complex illness. Off-label, which lots of medications are, that doesn't rule it out. I just think that right now it's a long ways from being used. Like all antibiotics, there can be side effects, stomach upset, allergic reactions, changes in blood counts. The mouse study used very low doses, and one thing that was appealing was that it seemed to be effective at low doses, which can reduce risks and side effects, of course. So that's one thing it really had going for it, that, other antibiotics may create more side effects and more risks. So what's next for piperacillin? Promising early stage evidence showed strong targeted activity against Borrelia in mice, maybe gentler on the gut microbiome, but human clinical trials are definitely needed to determine if piperacillin works safely and effectively in people for Borrelia infections. Researchers hope that an oral formulation might be developed to improve accessibility. I think that is definitely a requirement. And future studies will also need to assess effects in patients with co-infections, late disease, or chronic symptoms. So it's kind of like what we see so far looks good. We just don't have enough information. It's promising, but it's not a treatment that we're going to be able to turn around and prescribe next month. It's going to be a much longer road than that. All right, so next up is Tafenoquine. So I'll touch on Tafenoquine and Primaquine, but I'm mostly going to talk about Tafenoquine because it seems to be the more promising for us. Both Primaquine and Tafenoquine are part of the 8-aminoquinoline drug class, historically used for Plasmodium vivax and oval malaria relapses. So it is in the malaria kind of world, which most of the Babesia meds are kind of in the malaria sort of world. Their mechanisms are oxidative stress induction. So this is what it's doing to the bugs, is creating oxidative stress, disrupting the mitochondria, and possible persister cell activity are now being explored, mostly relating to Babesia, especially Babesia duncani, but I've used Tafenoquine in both patients with Babesia duncani and Microti. And honestly, sometimes we don't know if it's Babesia duncani or Microti. So that doesn't necessarily rule the use of Tafenoquine out or in for me. I don't think of it as a first line treatment. And, when I hear presentations at the ILADS conferences and et cetera, it's not typically thought of as a first line treatment. I usually will layer in other medications first. But we'll talk about that in a little bit here with more of the Tafenoquine. The Primaquine has a shorter half-life, so it requires more consistent dosing. Tafenoquine has a much longer half-life, so it doesn't need to be dosed as frequently. Primaquine can support with methylene blue to reduce oxidative complications and caution in patients with psych illness, anemia, or renal impairment, as is true for both those medications. The average dosing is 30 milligrams daily of the Primaquine. It has a short half-life, so it requires daily dosing. But like I said, the Primaquine, I'm mentioning it here, it's not what I would choose for Babesia if I'm looking to layer in one of these medications. So some side effects and risks, GI upset, nausea, anorexia, lack of appetite, abdominal cramps, methemoglobinemia, especially at higher doses, unlikely at doses that we're kind of typically utilizing. Hemolytic anemia, especially in G6PD deficiency. So we always want to be conscious of that. Neutropenia, low white blood cell count, corneal deposits, which is reversible and not damaging to vision, and neuropsychiatric events, which are rare, and I'll talk about a little bit more in a minute. So Tafenoquine is the more promising agent of the two, and Tafenoquine is what I've started utilizing in my practice. FDA approved for prevention and treatment of malaria, and single dose alternative to the 14-day course of Primaquine for Plasmodium vivax. So how we're seeing Tafenoquine working is sort of similar mechanism to Primaquine, but with greater lipid solubility. So that gives it better absorption, and typically the better the lipid solubility, or the better it absorbs into fats, the better it can cross the blood-brain barrier. Because the blood-brain barrier is really just like, one of my professors at Bastyr used to just say, it's just a big fatty baggie. Like it's basically lipid membranes. And so the more lipid soluble a medication is, the more it can sneak through those lipid membranes and have that blood-brain barrier crossing. It also has a longer half-life, so it can be dosed much less frequently. So again, mechanisms: sustained mitochondrial dysfunction and reactive oxygen species production within the pathogen. So it's messing up the pathogen's ability to create energy, and it's creating a lot of oxidative stress within the bugs. It targets both the acute and dormant stages, which I think is important, and I think it adds to our standard medications like Mepron and Malarone in that context. So we're increasing use in resistant Babesia cases. So these are my patients that have been on Mepron, Malarone, 2-3 months. We're not seeing enough benefit, or we have seen benefit, but then they've plateaued and we're kind of ready to ramp it up again. I would not just go in straight with Tafenoquine as a standalone treatment for Babesia. I layer it in with other treatments. So Atovaquone is probably our top medication for Babesia. It's the active ingredient in both Mepron and Malarone. So that's one of my first line therapies. Mepron, which is the liquid form of Atovaquone, must be combined with azithromycin or clarithromycin for it to work properly. Malarone, which is the tablet form, does not necessarily require that because it has proguanil in it, which is a secondary ingredient that kind of makes it work better. So the Malarone, the tablet form, does not need azithromycin or clarithromycin. The Mepron, the liquid form, definitely does better with one of those other two medications. But also synergy with doxycycline. I wouldn't consider doxycycline one of my favorite medications for Babesia, just in terms of efficacy. I don't really see that, but it can be part of that lineup if we have doxy in place for something else like Borrelia itself. So evidence of effectiveness from LLMDs and ILADS clinicians. We did hear quite a bit about Tafenoquine in the last couple of ILADS conferences, so it's definitely being used more. And I have certainly seen benefit from it in the majority of my patients. So dosing is typically 200 milligrams daily for 3 days, if somebody can handle that kind of loading dose. If they're more sensitive, we may skip the loading and start even lower. Dr. Marty Ross, who is very well known in the field, suggests 300 milligrams every 1 to 2 weeks for longer term suppression. So he's on the higher end. I typically will do 200 milligrams once a week. So there's two brands here, Crintafel and Aracoda, both Tafenoquine. To some extent, what we've been a little bit driven by availability of the different ones. There have been shortages along the way. And so I have used both Crintafel and Aracoda depending on what we can get our hands on. So the half-life is 17 days. It's long, which means it's good for weekly or bi-weekly dosing. It's not good if somebody has a not very good reaction to it, which I'm going through that with a patient right now. Had side effects. It takes a long time to get out of the body. So there's kind of pros and cons to everything. But with Tafenoquine, that's how it is. So adverse effects, possible GI symptoms, nausea and diarrhea, the corneal symptoms again, but that's reversible, no long-term effect on vision. Methemoglobinemia, which is kind of a long word that you're going to hear a few times in the next 30 minutes or so as we get into talking about methylene blue and Dapsone. But it's basically, it's a type of anemia and a type of a blood cell. We'll talk more about it. Hemolysis and G6PD deficiency. So we do screen for G6PD before starting somebody on Tafenoquine. Again, that is also true of methylene blue. That is true of Dapsone. So it's not alone in that sense. But G6PD is something that I'm trying to screen my patients for, as soon as they come in, just so we know what their status is with that. Very rare that someone has a G6PD deficiency, but it is an absolute contraindication for some of these newer medications that we're talking about. Psychiatric exacerbations, I have seen that. Increase in serum creatinine, which is more of a kidney kind of marker. Neutropenia, more related to the white blood cells. The one comment I will make about the psychiatric exacerbations is that Babesia can cause psych symptoms. And so we have to be really kind of careful here, because Babesia can cause a lot of like psycho-emotional symptoms. So when we start a new medication that's hitting Babesia, that's crossing the blood-brain barrier, we also need to consider that some of that may be part of a Herx reaction, like that may be part of the Babesia Herx. But we have to be very careful and kind of towing the line if there is like underlying psych diagnoses present. Drug interactions, notably metformin is the one that sort of comes up as the problem child. Not many of my patients take metformin, so it's not something that I have to consider a lot, but it is something just to keep in mind. And other oxidizing drugs like Dapsone, sulfur antibiotics. And we'll talk about those more in a little bit here. So clinical use and synergy often added after initial response plateaus to standard anti-Babesia protocol. So that's what I was saying. If someone's been on Mepron, Malarone for a couple of months, maybe they kind of went through their first round of Herxing, they've stabilized, things have settled out. That's a really good time to add Tafenoquine just to kind of give the protocol a boost. Maybe introduce once inflammation and down and detox pathways are open. So that's what I was saying. Like if somebody's going to have a Herx reaction, we want to support their detoxification, get through that with their standard protocol, and then layer in Tafenoquine. It pairs well with methylene blue, Dapsone, azithromycin, cryptolepis, and some of the other Babesia herbs. Cautious and sensitive patients, G6PD variant, I would not do it with G6PD problems, as I mentioned. So always checking status before initiating is important. Good in combination therapy. So that's what I was saying. It's great with Mepron, with Malarone, with azithro, with other things, more so than just a standalone treatment. It's a mitochondrial targeted treatment for persistent intracellular infections. And can be helpful for targeting persister cells, especially if Mepron or Malarone have failed, then it can be our plan B if we don't get any response for those. Good combos, like I said, atovaquone, Mepron, which is the liquid, plus Zithro, plus Tafenoquine. Malarone's the tablet, plus Tafenoquine. Tafenoquine and methylene blue. Dapsone, methylene blue, and Tafenoquine. That's kind of more advanced aggressive protocols. And that requires a lot of close monitoring, but it depends on what people are co-infected with, right? If we're dealing with Borrelia, Lyme, itself, and Bartonella, for example, then there may be more indication for, incorporating Dapsone into the protocol. So it really depends on what we're dealing with in terms of what chronic infections. Neurological considerations, they both cross the blood-brain barrier, meaning Tafenoquine and Primaquine. May induce neuropsych symptoms in sensitive individuals. So we do want to screen for bipolar, depression or anxiety, substance use disorders. But like I said, we also want to consider that it may in part be a Herx reaction, but we've got to play that one really, really carefully. And so we don't want to throw anybody into like a bipolar flare or anything like that that can be very dangerous. So just make sure if you are in that category, that if you are looking at doing this with a practitioner, that they are acutely aware of what you struggle with there and are really taking precautions to mitigate those things. All right, so there's an emerging hypothesis that mitochondrial disruptors like Tafenoquine and methylene blue may impair energy production in persisters and biofilm embedded Babesia. So that's good. We're hearing more about persisters. I feel like Dr. Horowitz, again, is sort of the pioneer here. In terms of these cells that are more dormant cells, they're often biofilm embedded, and we really need to be able to get at those cells to have like really good long-term effects. And that may be part of the downfall of some of our standard antibiotic protocols, that they're just not getting to those layers. Could act as a persister breaker when layered with other agents. May benefit patients with cyclical relapses and strong inflammatory flares. So just briefly here, does Tafenoquine break down biofilm? Well, it's not directly a biofilm agent, but it may help with biofilm just through these mechanisms we've talked about, targeting the intracellular and the dormant stages, enhancing mitochondrial disruption, creating oxidative stress. So it can weaken biofilm rather than being like a true biofilm buster, like kind of our favorites, lumbric-kinase, serrapeptase, bromelain, EDTA, and acetylcysteine, essential oils, Dapsone, methylene blue, some things that we know actually have an effect on the biofilm. it can help to destabilize the environment. So that can also be helpful. Monitoring baseline G6PD, this is going to come up time and time again. CBC with differential, just to watch the hemoglobin levels, the white blood cell levels. Met hemoglobin level can be really hard to get tested. I've struggled to get that specific marker on labs, but theoretically we should be able to get met hemoglobin levels. That's also really, really important in the Dapsone protocols. So it's something to consider. Creatinine, liver enzymes. I mean, we should be doing standard blood work, CBC, metabolic panel in, every case where we're doing antibiotics, antimicrobials, just to check and monitor levels every month. And then mood check-ins for patients with psychiatric history. Supportive therapies, of course, antioxidants, GI, microbial support. So in this webinar and the next one, I am actually not really talking about natural or naturopathic supportive therapies at all, because I've done a lot of webinars and a lot of education on that. I'm really honing in on these medications, but don't take that to mean that I don't think this is incredibly important. And I do these supportive therapies with all my patients who are on medications. I just frankly will not treat a patient with antibiotics alone. It's not in my philosophy of medicine. It's not what I see being the best, giving them the best outcomes, being the safest for them. So while they're notably absent talking about some of these more naturopathic approaches in these webinars, it doesn't mean that they're not very, very important. All right, so clinical pearls, just quickly, and then we'll move on. G6PD testing essential. Tafenoquine has a longer half-life, better efficacy in Babesia. Methylene blue can reduce the risk of methemoglobinemia, and combination therapy is best, not necessarily standalone therapy. Watch for psych effects, and as always, use with biofilm agents. So I think I've covered most of this. Supports advanced combination therapy models, and I'm seeing good things with tafenoquine. There's no one thing that works for everybody, and there's always somebody that's going to have a bad reaction to something that can be life-changing in a great way for somebody else. But the majority of my patients that I have on tafenoquine are doing well on it. All right, so let's talk about methylene blue. So a little history on methylene blue, developed in the late 1800s. It's one of the oldest compounds around. Was originally used as a textile dye and then became the first synthetic drug used in medicine. It was initially applied for malaria treatment and then became the gold standard for managing this methemoglobinemia, which we're still talking about, which is a condition where red blood cells can no longer effectively carry oxygen due to oxidative stress. Okay, so I'll say that again because it's important. Methemoglobinemia is a condition where red blood cells can no longer effectively carry oxygen due to oxidative stress. And so some of these medications promote methemoglobinemia, some of them protect against it. So methylene blue is a protector. So now it's got lots of uses. It supports mitochondrial function. So mitochondria, the little engines that produce our ATP, that produce our actual energy currency. It can help with cognitive performance. It has been shown to have some antimicrobial properties. So a lot of things that are helpful for Lyme patients, all rolled into one. So again, there's no perfect medication, but methylene blue has lots of great properties. So we know that in chronic Lyme, we have persistent infections, Borrelia, Bartonella, Babesia. They're the three Bs, I call them. I mean, we know we've got other co-infections like Anaplasma and Ehrlichia and Rickettsia, but the three Bs are the big ones that we deal with. There's a lot of mitochondrial dysfunction. There's a lot of oxidative stress, and that has an impact at the cellular health level. We have a lot of neurological symptoms, brain fog, anxiety, poor memory, and we have some medication-induced oxidative side effects. So remember I said some medications promote the methemoglobinemia, some protect against it. Dapsone actually increases the risk of methemoglobinemia. So that's why we offset that risk with methylene blue. So methylene blue has lots to offer. And I have seen it benefit a lot of patients. So I won't get too deep into the science here, but just suffice it to say that methylene blue can help with mitochondrial repair, which in turn helps with ATP production and cellular energy. And that then in turn feeds into the energy that we feel as, as humans, and our cellular resilience under stress, right? Oxidative stress is going to impair the mitochondria, and it's going to impair the cell's ability to produce energy. Now, it's not just, fatigue, the energy we feel, it's also the energy that's required to get nutrients into the cell, get toxins out of the cell, just keep the metabolic rate functioning, help our body detox. That all requires energy. So what I see it the most helpful for in my patients is fatigue, post-exertional malaise, and neurological sluggishness. I love that. Brain fog. It's like the Lyme brain. But a lot of people notice the two big things I hear the most are improvements in fatigue and brain fog. So it's kind of dose dependent too. So at lower doses, methylene blue is a powerful antioxidant and anti-inflammatory. So again, supports NAD plus cycling, which is essential for mitochondrial energy, cellular detox, DNA repair and longevity. Everyone's talking about NAD and anti-aging and all of that. That's kind of why. So it's antioxidant at low doses. It is pro-oxidant at high doses, but we're typically not dosing that high over any kind of long-term period. So that's unlikely to become a problem. So like I said, methemoglobinemia can occur as a side effect of certain medications in Lyme treatment that oxidize hemoglobin, reducing its ability to carry oxygen. Methylene blue is the primary treatment and prevention for this condition. So, Dapsone, Primaquine, Tafenoquine, you'll see here, especially with the Primaquine and Tafenoquine, I mean, we're not going to be giving over 300 milligrams a day, right? That's not going to happen. However, if there is some issues with that, the methylene blue is a good preventive. And that's why, as you'll see in a minute, it's very fundamental to the double dose Dapsone protocol, which is Dr. Horowitz's protocol, because those doses do get pretty high. So it restores proper oxygen transport. So if you have hypoxia, means low oxygen, so that's going to produce a lot of fatigue, shortness of breath, air hunger, which I realize are, babesia symptoms as well, but they're also symptoms of having not enough oxygen transport. So very helpful in the high dose Dapsone protocols. So then methylene blue also has antimicrobial and persister activity, especially against persister forms of Borrelia and Bartonella, possibly babesia, though data is more limited. I haven't seen it be as effective as an antimicrobial for babesia, but I do use it quite widely in my Borrelia Bartonella protocols. And I've seen it to be very helpful with that. It is dose dependent, so I'll talk about that in a minute, but methylene blue works really well with Dapsone, azithromycin, rifampin, doxycycline, and there's some of the meds that are lined up in the double dose Dapsone protocol. So it's kind of good in a multi-drug regimen for the infections themselves. But I'm using methylene blue in quite a few of my patients, not even as an antimicrobial, just really to help with energy production, brain fog, mood, things like that. And we can get away with lower doses for those uses. So it does cross the blood-brain barrier, which is great. So it enhances focus, memory, cognitive endurance, supports neuroplasticity, which is the ability of our brain to rewire itself, including memory extension, which is basically when the brain kind of unlearns trauma-based fear responses. This is really fascinating, and I don't have time to go into it in too much detail, but Dr. Moorcroft talked about it at an ILATS presentation a couple of years ago. But we know that a lot of Lyme patients have kind of almost PTSD-like patterns, and some of it is medical PTSD and things that they've experienced along the way. And Dr. Moorcroft was talking about how methylene blue can actually help the brain kind of forget those things, just extinguishing those memories. It can reduce air hunger and mental fatigue, probably by improving oxygen utilization. and mitochondrial efficiency in the brain. It's also used a lot in neurodegenerative conditions like Parkinson's, dementia, Alzheimer's, normal cognitive decline of old age. So it has historically been used for conditions like that. All right, cautions, contraindications. G6PD deficiency, you're going to get sick of me saying that, can trigger hemolysis, which is rupturing of the red blood cells. Drug interactions. Now, this is really important. So risk of serotonin syndrome with SSRIs, SNRIs, MAOIs. So we are always screening for people taking antidepressants. If somebody's on an SSRI antidepressant, I will not put them on methylene blue. There are practitioners that will say it's dose dependent. If someone's on a low dose antidepressant and it's a pretty low dose of methylene blue, it's probably okay, but that's opinion. I personally will not use methylene blue if someone is on an antidepressant. Avoid with amphetamines can just be way overstimulating and not recommended in pregnancy. I will say that, one of the things I see in methylene blue in patients that don't do well with it is they feel overstimulated. They feel like they've had 500 milligrams of caffeine. And so that is one thing I see. It also makes the urine blue, really blue. And so that's not necessarily harmful. It doesn't mean anything bad is happening. It's methylene blue is blue. And so that's just something to be aware of. If you're going to do mycotoxin testing, urine mycotoxin testing, and you're taking methylene blue, you need to be off it for at least a week or until your urine turns clear before sending in a urine sample. It will get rejected. So just if you're doing any urine testing, just bear that in mind. So I use lower doses, like for cognitive and energy support, 5 to 10 milligrams twice daily is a good starting point, or for more sensitive folks is a good starting point. 25 to 50 milligrams twice daily is kind of the slightly higher doses you need for more of the antimicrobial properties. So I just find tolerance-wise, lower dosing, or at least starting at lower dosing and working up from there, tends to be a better plan. And then a compounded form is recommended for purity and to avoid additives. I know some people order methylene blue on the internet, et cetera, et cetera. I can't speak for whether, the credibility of those sources, but for my patients, I always do it prescribed through the compounding pharmacy. So why do we like it? Protects the hemoglobin, boosts energy, which helps fatigue and brain fog, can be neuroprotective, so helping with memory, cognitive function, and emotional regulation. I've had a number of patients say that their mood just evened out in a good way with methylene blue. Can be helpful for persister cells and acts as an antioxidant for detox and reducing inflammation in the body. Okay, so let's talk about Dapsone. Now, Dapsone is an old mycobacterium drug. It was used for leprosy. It's not like a new drug by any stretch, but it's newer on the Lyme scene. And like I said, this was pioneered by Dr. Horowitz. Some of the advantages of Dapsone is it is typically once daily dosing, and some of his higher levels in his protocol, it goes to twice daily, but typically once daily tends to be easier on the microbiome. But again, it's not a standalone drug. And we've seen this in Lyme treatment over the years. Like, there's no one drug that we can come out with and say, okay, this drug by itself is going to treat Lyme, or this drug by itself is going to treat Bartonella. We typically will have combination protocols. And so that's nothing new, but it is also true for Dapsone. It's effective against persister cells of Borrelia and Bartonella. So that's kind of what it's best known for. And it can be very effective for that, but there are side effects that we need to be aware of that we'll talk about, and just be mindful it can cause very strong Herxheimer reactions. So Dr. Horowitz has come out with a double dose Dapsone protocol. But I just want to make the point that Dapsone doesn't have to just be used in the double dose Dapsone protocol. That's how we think of it, because that's how we've heard about it. And he's published some studies, and he's doing more research and really trying to kind of, get the word out there about the double dose Dapsone protocol. But it can be used in lower doses. So for more sensitive patients, like 25 milligrams of Dapsone with 100 milligrams of minocycline may be effective, and that's not the crazy high Dapsone doses. We can even start slower than that, 25 milligrams every other day for a week, and then go to 25 milligrams daily. And then depending on tolerance, then start increasing to 50 or 75 or up to 100 milligrams. At the lower doses, of course, it's going to have less side effects in terms of herxing, but also less chance of like the methemoglobinemia and some of those other things that we have to watch for at higher doses. Okay, so the origins of the double dose Dapsone protocol, and I will say this, let me be clear about this. I'm going to kind of talk a little bit about it. I'm going to give you snippets from it. This is by no means a comprehensive review of the double dose Dapsone protocol. Dr. Horowitz has published very, very detailed information on the protocol, on all the naturopathic integrative support. So this is just really more to highlight Dapsone as kind of a newer kid on the block and a new possibility to think about. But it's not a comprehensive review of the double dose Dapsone protocol or everything that is involved in that protocol. That would take an hour within itself, because it is a very involved, very advanced protocol. All right, so persister cells of Borrelia and Bartonella are problematic. Now, other bugs like Mycoplasma, Tularemia, Brucella also produce these persister cells. But this, the theory is that this is one of the reasons that Lyme is so persistent, for want of a better word, and so chronic and so resistant to a lot of treatment. So persisters can be round bodies, L forms, biofilm-like aggregates. They're like dormant cells, and they can revert back into active motile forms in favorable environments. So when we do treatments that address persisters, we also want to combine it with treatments for the more active forms so that we're kind of getting both parts of the problem. Biofilms play a large role for persisters, providing housing and a shield. So I feel like in the last few years, we've learned more about biofilms, and we're doing more to address biofilms. But biofilm agents, biofilm busters, are a vital part of Lyme/co-infection treatment protocols. I don't bring biofilm agents into play when I first start people on a new protocol. I like to kind of clear the first layer of pathogens, if you will. Like I always tell my patients, like if you picture that, you've got this like sticky goo here, like slime that some of the bugs can live in, and then you've got the free floating ones up here. We want to kill off these free floating ones before we start breaking down the slime and exposing more, because that just exposes more potential for Herx reactions. So I always like to get through like round one of Herx reactions, get things stabilized, and then bring in biofilm agents to try to get to the deeper levels. So some of the drugs that are effective against persisters, Dapsone, which we're talking about now, it is a sulfone. So it's still in the sulfa drug category, but there are many people who have like conventional sulfa drug allergies that can tolerate Dapsone. It also has some anti-biofilm activity itself, some anti-malarial activity, it's anti-inflammatory, good central nervous system penetration, can reduce autoimmunity. So it has a few different things going for it. Rifampin can be helpful against persisters. It's also effective against the active forms. So rifampin used primarily in Bartonella treatment. Pyrazinamide, which historically has been used in tuberculosis treatment, may just shorten the duration of treatment, certainly not a standalone medication by itself. Methylene blue, we've talked about already, persister drug for Bartonella and Borrelia, also reduces the side effects of Dapsone, that methemoglobinemia that you're sick of me talking about by now. And then macrolide, Zithro and Clarithro, lesser extent on persisters, but good in combination therapy. So we use those macrolides a lot in multiple antibiotic regimens. So again, just the overview, double dose Dapsone protocol. It's an 8-week protocol, historically an 8-week protocol. Dr. Horowitz reports 45 to 55% effective in getting people into remission. The 4-drug therapy was more effective than the 3-drug therapy. Now, I will say this about the double dose Dapsone protocol. It is heavy going. It is hard. It is a lot of medications. It's a lot of supplements. It's a lot of herxing. It's just a lot. It's a lot on the body. If you ask Dr. Horowitz, what he would say is, well, is it not better to just go on full attack mode for 8 weeks and potentially be done than sort of have months and months of these sort of long-term antibiotics, right? So that's the way he's looking at it, of like, if we can get in, go heavy, and, get out in 8 weeks or 9 weeks, depending on the possible pulses that I'll talk about, then, is that necessarily better or worse for the body than doing it the other way? So just a couple of viewpoints to consider. So in the double dose Dapsone, the dosing for Dapsone is 25 milligrams week 1, 50 in week 2, 75 in week 3, 100 in week 4, and then 100 twice daily, weeks 5 to 8. So there is a build-up period, but then weeks 5 to 8 is pretty heavy going at 100 milligrams twice a day. So 100 milligrams is considered a single dose, 200 is a double dose, 400 is a quadruple dose. So then we pair it with methylene blue to offset that methemoglobinemia. And that would be 50 milligrams twice daily, weeks 1 to 4, and 100 milligrams twice daily, weeks 5 to 8. So you can see in weeks 5 to 8, it's pretty hot and heavy. So now Dr. Horowitz has also included pulses. So this can either be done in the ninth week of the double dose Dapsone, and then once every 6 to 8 weeks. Or it can be done just as the pulses themselves without even doing the 8-week double dose Dapsone protocol. Typically pulses will be 4 to 6 days, but more leaning towards the 6 days, especially in Bartonella, but likely in Babesia as well. So like I said, I have not listed out all the medications and all the support and all the supplements, etc. But just honing in on those pulses, then for Dapsone itself become 400 milligrams. And 300 milligrams twice daily of methylene blue, which that's a lot. My thought would be that that's very, very high doses to be taking without working up to them. But he has done it. I have not done that in my patients to go straight down to the high dose pulse. But he has done that. And it's also unknown how many pulses are required to get the same results, so to get to the point of, hopefully the point of remission for a patient. Now, again, every practitioner is going to have different opinions. So for Dr. Horowitz, if he feels like he's dealing with a patient with mold, which I feel like more and more of our patients are, he'll do the 9-week protocol, then go to mold treatment, and then stop mold treatment if he's pulsing again. So he'll kind of do the 8-week double dose Dapsone, potentially add on the 9th week, and then sort of deal with mold in the in-between times, in the gaps, if you will. For me personally, I would want to do a much more thorough mold work up first and try to detox mold or mycotoxins as much as possible before even going into Lyme antibiotic treatment, just to try and get the most benefit out of treatment with the least side effects. So it's just a question of different practitioners will do things in different order. So double dose Dapsone also requires many other medications, rifampin, hydroxychloroquine, which is Plaquenil, Doxy, nystatin. I mean, the list goes on. Naturopathic support, detox helpers, probiotics, antioxidants, biofilm agents, all the things. So yeah, this is not a complete listing of the protocol. So caveats with methylene blue and Dapsone, because I've talked about like how important methylene blue can be to offset the side effects of Dapsone, especially at the higher doses. So then what if someone's on an antidepressant medication, which then sort of makes the methylene blue contraindicated? So that's where it gets a little bit tricky. We don't want to create serotonin syndrome amongst everything else. That would get very, very detrimental to our patient. So methylene blue is not the only antioxidant there. I mean, there are other antioxidants like NAC, glutathione, vitamin C, alpha-lipoic acid. So if we have to, we can utilize other natural antioxidants rather than just methylene blue. But in talking to Dr. Horowitz, he will actually have his patients discontinue antidepressants during the protocol, during the double dose Dapsone protocol. So again, risks of that, side effects of that, downsides of that, all of these things have to be weighed up, especially at looking at doing the double dose Dapsone protocol, because there is, with the higher doses of Dapsone, much more potential for side effects. Methylene blue is one of the best things that we know to offset those side effects. But if one's on an antidepressant or has G6PD, rules out all of it, of course, deficiencies in G6PD. But some patients would absolutely crash and burn getting off antidepressants, especially quickly. So definitely pros and cons to that. Okay, so summary of cautions with Dapsone: check G6PD first, also for methylene blue and Tafenoquine. Checking CBC, metabolic panel, especially looking for the hemoglobin, met hemoglobin levels every 2 to 4 weeks. Must give additional folate, so leucovorin, methylfolate supplements, and balancing the methemoglobinemia with methylene blue and antioxidants. Watch for very strong Herx reactions, so supporting detoxification as much as possible, building the dose slowly, so people can utilize Dapsone without doing the double dose Dapsone protocol, as I said, and go much more slowly on dose. That is definitely a possibility as well. Allergic rash in approximately 5% of patients with a sulfur drug allergy. So kind of a low percentage, given it's sort of in that sort of vague family. But most with a sulfur drug allergy can tolerate Dapsone, but of course that's something to be very watchful for in the beginning. All right, so we got through a lot of information. Hopefully that was helpful. What I'm going to do now is stop sharing my screen and let me look at the Q&A and the chat. We have a little bit of time. Okay, so a question about the G6PD. So that's a standard blood test. We do a quantitative G6PD, can be done through LabCorp, Quest, any lab. It's not hard to find. It's not a specialized functional medicine test. It's quite standard blood work, so that's not so hard. Claire's asking, I've heard that methylene blue stains toilets permanently. Is there any way to prevent this? So what I found here is it depends on where the methylene blue comes from, to be quite honest with you. There's some methylene blue, from a compound, it all comes in capsules. I have not found the majority of my patients complaining of that. So I haven't heard that there's like permanent staining. Definitely it makes urine blue. But I haven't had really anyone complaining that their toilet is stained permanently. So I can't really address how to prevent that. And it may be dependent on the pharmacies too. Like I have one pharmacy here near me in San Diego that their methylene blue is like granules. It's still within a capsule, but it's like granule form. And then another pharmacy I use, InfuServe America down in Florida, theirs is going to be more of a liquid form. So it may be that the granule form is a little bit easier in that respect. Scientific citations for and dosing guidelines for ivermectin in treating Lyme. I mean, not right now, like I kind of gave you that very broad range. So that's not something that I can pull up right here. Let's look in the chat. Let's see. Yeah. So a comment isn't, will the slides be shared out? I certainly was going to share the recording. If you want the slides, just when I send out the recording, just pop me an email back and I should be able to do that. Liam, isn't ivermectin good for biofilm as well? I haven't really looked into that. Ivermectin seems to be like one of those medications that had lots of like interesting and surprising uses. So I wouldn't put it past it. But that's not, I wouldn't think of it. That wouldn't be my first thing I would grab for a biofilm, putting it that way. Do I treat patients for mast cell activation syndrome? Yes, I do. And that is coming up more and more, and maybe I'm recognizing it more and more, and kind of trying to pay that attention before we get to anything else. So patients with mast cell issues are frequently very reactive and don't tolerate a lot of things. And so if we don't work on getting that tolerance better, then we're going to be limited in what we can do and what treatments we can use. So I'm sort of starting to get more like train myself better to look for mast cell issues first. They're not mast cell activation syndrome. There are some lab markers like tryptase and histamine and things like that, but it's not something that you can really, like there's a classic lab panel or a blood work panel for it. like I said, there are different markers, but there's so many different mechanisms and so many different chemicals related to mast cell issues, that just kind of looking at tryptase or histamine or something is kind of limited. So I'm really trying to look at what's going on with the patient, where are their reactivities, if they have multiple system issues, like a lot of food intolerance, bladder irritation, itchy skin, hives, rashes, anything like that, heat intolerance, then I do think about mast cell activation syndrome. And so I will try and start there. And that could be a whole other webinar. Maybe I'll do a whole other webinar on it. But there's multiple layers of how I look at mast cell, everything from, low histamine diet to DAO enzymes to some herbs and nutrients like pyramine, quercetin, that can help, vitamin C that can help stabilize mast cell issues, H1, H2 blockers, like even some of the basic over-the-counter pharmaceuticals, like an Allegra coupled with Pepsid, so for H1 and H2 respectively. And then there's some mast cell stabilizers like gastrochrome, ketotifen, low-dose naltrexone, we'll talk about that. GLP-1s are starting to show promise for people with histamine issues and mast cell issues. So that's kind of an exciting development as well. But I feel like if we need to get that somewhat stabilized first. So my order of go nowadays tends to be trying to stabilize mast cell issues and get the reactivities down, then looking at mold and mycotoxins, try to clear that up as much as possible, then kind of going into more of the Lyme and chronic infection treatment. Sometimes with mycotoxins, we can marry both, like we can be sort of detoxing mold, chipping away at that while we're addressing the infections. But if somebody comes with like crazy high levels of mycotoxins, then I really feel like that needs to be the first stop before we can effectively treat the Lyme and the tick-borne infections. So what I'm going to do is just one more time, I will grab that link for the part 2 update, just in case you want to sign up for that one. I'll put that in the chat. But yeah, thank you so much for joining me. I hope this was helpful. I try to give like clinically relevant information and not get too science, like too weighted down in science, and make it that you guys can understand clearly. So hopefully I achieved that. Next time we're going to talk about LDN, we'll talk about SOT, we will talk about the GLP-1. So that's going to be a really fun conversation, probably a little bit less heavy sciencey. But anyway, so thank you so much for joining me. Enjoy the rest of your day or evening, wherever you're located. And I will see you again very soon. Bye.